Good evening, everyone. So we welcome you all to the e-classes which are being organized by Wincars. And it's really fantastic to see all of you together on a working day at 7:30 come to join us. These e-classes are basically for the fellows who are going to appear for the exam. And this will be a case-based discussions. They will present their cases and which will be evaluated by senior faculty who there are the stalwarts in their field and followed by a small 15 to 20 minutes tips and tricks in the examination, what all to be learned about and what all not to miss. So for the today's session, we have a case of approach to a case of religion lesion. So may I ask Dr. Usha to introduce the speakers and the presenters for the session?
Yeah, so today's case is, as Dr. Rupali said, valvular regurgitant lesion. Our senior professor, Dr. Prabhavati, will be discussing the case. Dr. Aditi, the second year postgraduate resident from our hospital, from Jaydeva Hospital, will be presenting the case. Dr. Murugesh will show the case slides, echo, and ECG. And the chairpersons for today, Dr. Sujata and Dr. Jyotsna Madam and Dr. Chabi will also coordinate the case discussion. So I think we can go ahead and start the case discussion. We have around 30 minutes for case presentation and discussion, around 15 minutes for a short didactic lecture, and then there will be an open forum for discussion. All students and residents should feel free to discuss, ask questions, and unless there is an interaction, only then we'll have a fruitful learning experience. So let's start the program. Dr. Aditi, can you go ahead with the case presentation?
Good evening, everyone. I'm going to start the case presentation. An 18-year-old male, resident of Kuningal, studying in second year PUC of low socioeconomic status, presented with chief complaints of fatigue since the past 4 months, palpitations since the past 4 months, cough with expectoration since the last 4 months. There is history of bilateral lower limb swelling since the past 20 days and history of abdominal distension since the past 20 days. Patient gave history of fatigue since the past 4 months. It is exertional in nature, gradually progressive. Initially was in NYHA class 2. Since he has stopped going to college in the past 4 months because he is unable to climb one flight of stairs also in his college. And it has progressed to class 3. That is, right now, he's unable to do even his routine daily activities like having bath, etc. since the past 1 month. There is history of palpitations since the past 4 months associated with mild exertion, insidious onset and offset, lasting for around 10 minutes and resolving with rest. They are not associated with any giddiness or syncopal attacks. There is history of cough with mild whitish expectorations since last 4 months, episodic in nature, not associated with any diurnal or postural variation. There is no history of fever, hemoptysis, or dyspnea present. There is history of bilateral lower limb swelling since the past 20 days, which is insidious is onset, gradually progressive, started initially at the ankle region, and it has progressed up to a mid-thigh. It is more noticed in the evenings, according to the patient, and it is decreased in the morning on waking up. It is not associated with any pain or redness. There is history of abdominal distension since past 20 days, insidious onset, gradually progressive, diffuse in nature. It started at the same time as the pedal edema, but it is not associated with any abdominal pain, bowel disturbances, yellowish discoloration of eyes or body. It is associated with breathing discomfort since the past 2 weeks. There is no history of any chest pain, orthopnea, or paroxysmal nocturnal dyspnea. Reviewing the past history, patient had one episode of fever with multiple joint pains at around 9 years of age. He was evaluated at a cardiac center for the same, and he was told to have a heart condition and advised to take IM injections every 21 days. However, a patient defaulted on those injections after 2 years. Then he had a similar episode of fever with multiple joint pains at around 12 years of age, for which he received no treatment. Following which the patient developed cough, exertional palpitations, and class 2 dyspnea for 6 months. This progressed to class 4 dyspnea associated with PND episodes. So he was admitted to Bangalore Jaideva for the same time, for the period of time, for around 20 days. At that time, he was intubated and he was on mechanical ventilator. He was treated with medications, post which he was advised for surgical intervention and a date was given accordingly. He was admitted around 1.5 months later following this event in May 2019 around, that is at around 13 years of age, for open heart surgery. Following surgery, he was...
Dr. Anina, can I just interrupt? Your slides are not changing. It's still on the first slide.
Yes, sorry, ma'am.
So, can I request the chairpersons, but end of the history, what's the plan? Can we have a discussion with this? Jyotsna madam?
What I thought is we'll finish the history and then we can ask them to summarize, and then we can go for the discussion.
I think she
Then
hasn't
end up the clinical examination
So
once
just,
again.
okay, ma'am.
Is it completed? I don't think it's completed, Pooja.
No, ma'am, no, just a few. Yeah. Okay. The following surgery, the patient was continued on oral medications and he was also advised to continue penicillin injections, that is IM injections. However, patient defaulted the medications as well as penicillin injections. Patient tells that after surgery, he was asymptomatic and he has developed symptoms which I presented in my HOPI since the past 4 months only. There is no history of any diabetes, hypertension, TB or TB contact. In personal history, his appetite is reduced, normal bladder and bowel.
Slide is not moving again.
Slides, no, we're not moving. Can you just change the slides also when you're just coming to the history part?
Appetite, family history, insignificant, no history of any addictions. So, to summarize the case, an 18-year-old male presented with history of acute rheumatic fever at around 9 years of age. He was on penicillin prophylaxis, which he defaulted, following which he presented with cough, palpitations, exertional in nature, and dyspnea at around 13 years of age. Following which 1.5 months later, he underwent open heart surgery in May 2019, and following which he was asymptomatic till past 4 months. Now he is currently presented with exertional fatigue, palpitations, bilateral pedal edema, and abdominal distension. So my differential diagnosis, most likely, I feel it is a valvular heart disease, likely rheumatic in etiology.
Pooja, just wait for 5 minutes. So you just give a clear summary of that. At what age the patient becomes symptomatic, what were the symptoms, how long he received the injections, and he defaulted, then when the symptom occurred, and he went for surgery, and again when he becomes symptomatic. You just give a little clear idea. We are a little confused.
Okay, ma'am. When he was 9 years older, he had acute rheumatic fever episode. At 12 years of age, he became symptomatic. He had cough, exertional palpitations, dyspnea, which was class 2 symptoms, and it progressed to class 4.
So following 3 years of initial attack of rheumatic fever, the patient becomes symptomatic.
Yeah, after 3 years, after 3 years, at 12 years of age, he became symptomatic. For 6 months, he had the symptoms. It had progressed to class 4 dyspnea, and so he was admitted in Jaideva Hospital for treatment. After which 1.5 months later, he was readmitted for surgery, that is open heart surgery. At that first admission only, he was told that he needs a surgery. So 1.5 months later, he came back for surgery. He underwent the surgery, following which he was asymptomatic. He continued oral medications for 1 year, and penicillin injections he continued for the last 4 years. Last 4 months only, he has defaulted the penicillin injections. And now, since past 4 months, he has presented with exertional fatigue, palpitations, and bilateral pedal edema and abdominal distension since 20 days.
Okay, with this history, what you think that most likely the first episode, what is required for the mitral valve replacement, and now what is the responsible for the subsequent symptoms?
Yeah, like before, ma'am, there is a valve repair done, I feel, because the patient was not receiving, he was given oral medications, but there was no history suggestive of any warfarin, like 6 p.m. any medication or any blood thinning.
I don't think your analysis has to be started in the way it progresses. You
Right,
had
right.
to rely more on the natural history than the taking the penicillin penicillin prophylaxis is there or not. Because his rheumatic history is at the age of the 9 years, and he progressed rapidly within the 3 years
Right.
to the 12 years. By the presentation is the pulmonary edema, according to you. It is not the right
Yes.
heart failure. It is a pulmonary edema is a cardinal symptom of the left heart failure. So he
Yes, ma'am.
presented with a left heart failure, and progression is occurred only the 3 years, which is the classical in the case of the rheumatic, juvenile
Right.
rheumatic diseases in India. Or otherwise, it is not a natural history of the mitral stenosis or the any mitral regurgitation doesn't say so rapid progression then occurs. And then he had a major presentation is a pulmonary edema, which is responsible, which we required a ventilation. So, what type of
Right.
the valvular lesion is likely to develop the pulmonary edema as a major predominant presenting feature, which requires in short to go for the mitral valve replacement.
Right. You have to
Mitral-
analyze properly. You have to analyze properly each of the thing you are saying rather than going immediately to the surgery and all. What happened initially? Why within 3 years? What was the valve presentation? Why he went to pulmonary edema? If it is regurgitation, you just analyze. You tell us why. Each and everything you tell us.
Yeah, ma'am, because it is dyspnea is a predominant symptom, it could be mitral stenosis, but because it has progressed so rapidly, it is just 3 years after the acute rheumatic fever onset, the patient has presented with pulmonary edema. So it could be because rapid progression of dyspnea can also be seen in mitral regurgitation with recurrent ARF episodes. I mentioned, there are 2 ARF episodes he had because he was defaulting on penicillin injections. So that could be the cause for the rapid progression of dyspnea. If it is MR. In MS, since it is a very short, latent period, only 3 years, it is less likely that it will progress to chronic rheumatic MS, and the patient will present with dyspnea, pulmonary edema, and all. So
Can
I
I,
would,
can I reframe your sentences
Yeah.
a little bit?
Yeah.
The major
pul-
thing is actually what is rapid progression over the 3 years for the mitral regurgitation, unless the LV dysfunction then occurs, is not a feature. So you should not get a regurgitant lesions as the first possibility for this. On the top of it, if you say the mitral stenosis, either the progression of the rapid progression of the mitral stenosis, which is the cardinal feature, is the pulmonary edema. So without the left heart, left ventricular ejection fraction decrease, it is an MS which can have the pulmonary edema features. So you should bring the mitral stenosis as the first possibility in this than MR. Just because now you have the symptoms of the regurgitation doesn't mean that the mitral valve replacement also has to be done for the same. It could be because of the MS also. Then second possibility is MS will rapidly progress when the juvenile rheumatic and heart diseases than the MR, even though the MR is the commonest lesion. But the rapid progression is not known to occur so rapidly as in the case of the juvenile MS. And a third important feature, what you had it at the time of the presentation, is the pulmonary edema, which is not a feature of the case of a MR. It is a feature of case of the MS. Second point, what you said is very, very appropriate, because rheumatic and fever activity, that in turn you have to say that the myocarditis, that is responsible for the development of the pulmonary edema. Then they don't advise in replacement within the first admission itself. So you have to bring the DD as one of the possibilities as the rapid progression of the MS. A second one is in myocarditis or other precipitating factors like the arrhythmias, and then associated then other valvular heart diseases. You can rule out then other things by saying that the rheumatic and heart diseases, the progression is more likely to be with an MS is more likely, but with other regurgitant lesions is less likely, or associated valvular heart disease in the juvenile variety of rheumatic is very less frequent. So the other associated lesions, all of them contributing to one single valve replacement is also is less likely. And myocarditis, because of the rheumatic fever, they don't advise the surgery immediately. So, in conclusion, you say that MS probably is responsible for his mitral valve replacement at this stage. I want now the second part to you to analyze like this. Faster.
okay. Post which the first surgery he had, and because he was continuing medications for some time, he has defaulted. Now there is recurrence maybe of the old lesion. It could be a stenotic, or post the surgery, it could be a regurgitant lesion as well, or a combination, which has now developed into pulmonary hypertension with RV failure. So because now the patient predominantly has abdominal distension and pedal edema, the right-sided failure features are more prominent, and it is masking the left-sided symptoms. So it could be the
Okay,
left
but
side.
with this history, what do you think?
Wait,
Fatigue and palpitation as a predominant features.
Uh,
Which lesion you wanted to consider?
Yeah,
That's what madam is
the
asking.
first lesion
Yeah.
is a mitral regurgitation I would like to consider, and that is causing pulmonary hypertension over a period of time with right now right-sided RV dilatation and RV dysfunction.
Excellent.
Now,
So
how is in the second part of your history, how was the progression of the symptoms? The patient presented with abdominal distension and liver enlargement, or the patient presented with cough and all? How the patient present? How is the progression?
No, the patient, ma'am, since 4 months he is having fatigue and palpitations, but the abdominal distension and pedal edema is since 20 days. So he came because of the distension and pedal edema. Like he presented because since 20 days, because the abdominal distension and pedal edema gradually worsened to the
Okay.
current stage, he was admitted.
What about your cough and hemoptysis when they came?
No, there's no hemoptysis, ma'am. The cough is mild, with mild expectoration. It is not associated with any PND or orthopnea. So it is like it could be there could be some pulmonary venous hypertension as well. But because right now the right-sided features are more prominent, I think that the pulmonary venous hypertension may not present so floridly as much because there is right-sided failure.
No, in the duration of the symptoms, the patient presented the duration of your distension of the abdomen and all for 2 months, right?
For 20 days, ma'am.
20 days. Even the cough and hemoptysis are also for 20 days?
No, that is for 4 months, ma'am.
4 months. So first presented with cough and hemoptysis. Later on, it went on to congestion of the rights.
Right.
So
Yes.
what do you think out of it? What do you think out of it?
Ma'am, more than cough and hemoptysis, it's actually he complains of palpitation and
Yeah.
fatigue, ma'am. That is
Palpit-
the
Now,
predominant.
question is, your palpitation and fatigue is possible in both the regurgitation, whether it's a mitral regurgitation or it's a tricuspid regurgitation. These are same. They will present with fatigue and palpitation. I think whether it's a mitral regurgitation or it's a tricuspid or mitral regurgitation gone to PH with tricuspid regurgitation. What do you feel?
yeah, it's a good point that both regurgitations can have the right heart failures and the fatigue. Fatigue is a feature of the heart failure.
Yes.
So the problem is in the rheumatic and heart disease, what is likely lesion to then develop either the TR because of the secondary pulmonary arterial hypertension and significant the TR, or organic tricuspid stenosis. So organic tricuspid stenosis will differently present that there is improvement in the symptom of the left heart failure and the predominant right heart failure symptoms. But in this case, the patient continues to have the dyspnea. In
Right.
addition, had the right heart failure. So
Right.
it is less likely
This
that
time
the
there is no
patient has
dyspnea.
developed a second lesion. Okay, you are able to understand up to that point. But as you said, the palpitation, that too exertional, not related to the arrhythmia, like symptoms are not there. Most likely, it is the possibility that the patient has a mitral regurgitation. Good, excellent. Can you go further because we have only half an hour for the discussion?
There is no
Yes.
dyspnea this time, Aditi.
No, ma'am. This time he's not complaining of any dyspnea also. Only like abdominal distension, pedal edema for which he has come. On fatigue and palpitations is on asking, like because he left college, so he told me that he had fatigue and palpitations. That's why he was unable to go to college.
Now, regarding cough and all, how are you attributing? If there's no cough, it's a different thing. But he is having some form of cough and something you are saying.
He has, ma'am. He's telling there is cough, but it is not it is episodic in nature. It is not a continuous cough for past 4 months. Intermittently, it is happening. There is no hemoptysis. There is no other features like dyspnea, orthopnea, PND. Exertional dyspnea is also not present. So that is why it is like more of right now right-sided failure features are more prominent as compared to left-sided features.
You can.
And
go on.
can we go to examination? I think we have already
Right.
for
We can-
20 minutes history.
Yeah, and we request the students to type their questions and someone has to take care of those questions so that we can answer in the end, because everyone may not able to put forward their ideas. Please go ahead, Amma.
Ma'am, on general examination, patient is conscious, cooperative, lying in supine position. He's poorly built and poorly nourished. Height is around 155 centimeter. Weight is 43 kg. BMI is around 17.9. Arm span is equal to height. On examination, pulse rate is 110 per minute regular, normal volume, no special character, no radial or radiofemoral delay, and all peripheral pulses were well fed. The BP in the right upper limb was 110/60. The left upper limb was 160 and the right lower limb was 120 systolic. Saturation was around 98% on room air. Respiratory rate is around 22 per minute, abdominothoracic. His JVP is elevated up to angle of mandible in 45-degree posture. V waves are prominent along with Y descent. There is evidence of pallor, icterus, and bilateral pitting pedal edema. There is no feature suggestive of acute rheumatic fever or infective endocarditis.
Okay, at this stage, what is the most likely positive findings you got it to say that points out to your diagnosis?
Elevated JVP, ma'am, with V waves and prominent Y descent. So that
Play the
could point
video,
that it is
Aditi. It's not seen. Video is not seen, Aditi.
not playing.
Yeah, do you want to say how much it is elevated? You are just saying it is elevated and the V wave is positive with the descent.
It is up to the angle of mandible, ma'am.
Up
Like
to the
almost 10 to 12 centimeter.
Right, good.
And one more thing is systolic pressure in the presence of the heart failure recording, is that giving any importance to you?
Can you come again, ma'am? Sorry.
Blood pressure recording, is that going to be helpful in any way in a heart failure to know the cause?
Ma'am,
We didn't understand the question.
no, I can't hear, ma'am, actually. Please.
Ma'am, can you unmute yourself, Jyotsna madam?
Okay, sorry.
Yeah.
I am not unmuted. I am unmuted.
Yeah, now you're audible, ma'am.
I'm audible.
audible.
Okay. I am asking, what is the blood pressure you wanted to be expect to be present in a case of a heart failure?
It will be lower side, ma'am. Like systolic blood pressure will be lower. Diastolic, and there'll be narrow pulse pressure. There can be narrow pulse pressure.
So that you are not able to in this you are having 110/60, which is not a feature of the heart failure. So
Please tell
what
others
is the
to mute.
lesion which can have these type of the features, like narrow pulse pressure is not there, systolic decapitation is not there. And so what are the likely possibilities you suspect in a heart to lead to heart failure? Got my point? Or I am not clear?
Yes, ma'am. Like mitral regurgitation, chronic MR can present with normal blood pressure as well. Or chronic, like MS also, because there'll be left atrial hypertension and pulmonary edema, there'll be heart failure, but BP may be normal.
No, MS is classically, you will have the low cardiac output states subsequently. But as you said, then MR and AR is another one. AR is another one where you will have the persistence, slight pulse pressure is still maintained even in the presence of the heart failure. And in the MR is also is known to have like that. Okay, go ahead. And if the video plays is good, and if not, you go ahead. So prominent V and Y descents, what it says.
Yes, ma'am. On cardiovascular examination, inspection.
One more thing, Ramesh has said that wide pulse pressure for the AR, but AR, classical AR without left heart failure or the heart failure, then you will have the wide pulse pressure. But once then LV dysfunction occurs or the goes into the heart failure, you don't get the wide pulse pressure. Please go ahead.
On inspection, chest wall is symmetrical, vertical scar is present in the midline. Apex beat is present in the left 6th intercostal space, 2 centimeter lateral to the midclavicular line. It is hyperdynamic in character. There is a grade 3 parasternal heave, which is present in the left parasternal area. There is a palpable P2. Prominent epigastric pulsations are seen and felt. And there is a systolic thrill present at the apex and in the left parasternal area.
Go for complete examination of the CVS. Otherwise,
on percussion, the left heart border is corresponding. corresponding to the apex. The right heart border is 2 finger breadths lateral to the right sternal border. The left costal space is dull to percussion. On auscultation, the first heart sound S1 is soft, S2 the P2 is louder. There is narrow A2 P2 split. There is a pansystolic murmur in the apex, grade 4/6, high pitched blowing, radiating to the axilla and back. Best heard in the left lateral position with the diaphragm of the stethoscope in end expiration. There is another pansystolic murmur which is heard in the left fourth intercostal space, grade 5/6, medium pitched, increasing with inspiration and best heard with the diaphragm of the stethoscope. There is a mid-diastolic murmur at the apex, grade 2/4, soft, low-pitch rumbling, best heard in left lateral position with bell of the stethoscope. There is no pre-systolic accentuation. There is S3, which is best heard in the left parasternal area. So, according to me, it is more likely an RVS3. Respiratory system examination, bilateral normal vesicular breath sounds, and abdominal examination, uniform distension is present. Hepatomegaly around 6 to 7 centimeter below the right costal margin, non-tender, pulsatile, and shifting dullness is present. No splenomegaly. The CNS examination is within normal limits.
One question is, patient has a mitral valve repair or replacement?
No, ma'am, it is repair, ma'am, actually.
Repair.
Because
why you are so certain that it is a repair, not a replacement?
No, one thing is, I asked him for that whether he was advised for any blood thinner medications. He said no, and he was also advised to continue penicillin prophylaxis further. So, like.
No, penicillin prophylaxis doesn't say that the patients require the replacement versus this thing.
No.
For both, it is requires. But one point, as you said, the anticoagulation for only given for 6 months for the repair, whereas in the for replacement, the prolonged is good. But another important, I'm asking this question to you after the clinical examination. You have not heard about the prosthetic sounds at all. The absent prosthetic sounds. Absent prosthetic sound says that either there is a dysfunctional prosthetic valve or there is no prosthetic valve at all. Okay.
Pooja, I want to ask you, the patient is in gross congestive heart failure, your JVP is at the angle of the mandible, right? Still you say the pansystolic murmur at the left sternal border is increasing on inspiration and the second heart sound is narrowly split, right?
Yes, all those signs is not possible because the inspiratory variation goes off in the case of heart failure. Not only that goes off, it is supposed not to be done. Right. All these maneuvers are the contraindicated to do it. And you don't expect it in the heart failure. Inspiratory increase of the right side even doesn't happen.
And whatever the narrow splitting of pH, again, it widens when the patient's RV is failed and that to JBP is at the angle of mandible, right? So again, it splits wide.
You to put your final slide of the diagnosis, then we can know all your controversies because the presentations is like a classical features for the every disease, every lesion you mentioned. But as madam is saying, heart failure will modify everything, which you are not paid attention when you are discussing about it. That you have to think at the time of presentation.
My final diagnosis is acquired valvular heart disease of rheumatic etiology with severe mitral regurgitation, with severe tricuspid regurgitation, with severe pulmonary hypertension, status post mitral valve repair in 2019, currently in congestive cardiac failure, mostly right-sided heart failure, in normal sinus rhythm, with no features suggestive of acute rheumatic fever or infective endocarditis in NYHA class 4.
And you heard about a MDM at the apex and everything is just because of the severe MR?
Yes.
So, can you say, because there is no time, silently can you say why you said severe MR, why you say severe TR, why severe PAH? What are the 3 cardinal signs? You have it for severe MR?
Severe MR, ma'am, it is down and out apex. There is MDM is present.
Cardiomegaly, gross
cardiomegaly. And there are features of pulmonary hypertension as well. Like there is parasternal.
No, those are the secondary. Direct.
You tell direct 3 evidence. Direct 3 evidence.
S3 is RV S3, ma'am.
Why RV? We are asking about severe MR. Why are you going to RV?
No, ma'am. There is no LVS3, ma'am.
There's no LVS.
No,
That
ma'am.
is required for a severe MR. You do not have anyway.
Yes.
But
So
cardiomegaly,
that is goes against of it.
MDM is there.
right? Right.
Yes, ma'am. MDM is there.
MDM is there
So-
and cardiomegaly.
Yes,
LVS3 is not there, which you should get. Okay.
And for severe TR, ma'am, CV waves in the
No, actually say absence of the S3
Yeah,
goes
yeah.
against of severe MR.
So is that
MDM,
normal? Right.
presence
Is,
of the S3 and split of S2. These are the three cardinal signs
yes,
for
yes.
you to say that severity of the MR. If the one of them, an important thing is early offense is S3. S3 can be present in the moderate to severe. But whereas the split of this in S2, gross changes will occur in the severe MR only. And cardiomegaly is variable depending upon post-surgery. Now, the post-surgery, you can't depend upon the apex beat location.
Yeah.
That the giving the incision itself will alter it. So these are the limitation for you to say the severe MR. Now go for severe TR.
severe TR, ma'am, CV
Yeah,
waves
just
in
Pooja,
the
you-
JVP
Pooja-
with prominent Y descent.
Yeah, Pooja, you got it. What madam is saying is very important. In this patient, your splitting is narrow rather than wider. You didn't get S3 and thus a diastolic murmur. So could it be associated MS? You didn't get S3 and the narrow splitting, it's not wider.
There is no other features, ma'am. S1 is not louder. There is no opening snap. There are no associated features like of MS and MDM is also only non without any presystolic accentuation. So I don't
No, you note down these questions and try to
Okay,
answer
okay.
because it's a time limitation.
Right,
So
very
you
good.
note down this. All important point what Sebi madam is saying is an important because these are the controversies. And the severe TR you started with the prominent Y descent. I would have been happy to say that if it's a CV wave, the
Yeah.
prominent V wave than the prominent Y descent. So you have to be very, very certain when you are using a specific words on the bedside. Our main aim to train you is to for those things. Okay. So
Nice.
what is the cardinal sign for the severe PAH? Tell me the three cardinal signs what you got it to say severe PAH.
Ma'am, loud P2, palpable P2, and left parasternal heave.
Loud P2 doesn't say severe PAH, madam. That's what whenever you use the word, please be careful.
Severe
Loud
pitch.
P2, which is heard at the apex.
Apex, yes.
So we are asking what are the features of severe pitch. It's not just pitch. You should be very clear. Mild, moderate, severe. The question is the features of severe pitch. You should stick to your question. Loud is possible with moderate pitch also. It should be audible up to the apex and should be palpable, right?
Yes.
Right.
Okay. Can you then go to the other examination? Loud P2 heard at the other areas apart from that. Okay. That is one of the sign someone is answered about it. So you go for the other investigations. There is a lot of things will be there to discuss actually for the bedside. But our aim is to stimulate you so that you write the questions next time when you come back so that we can have a group and have the discussion further about these questions than didactically go because it's a limitation of the half an hour. So you wanted to have then any other investigation modalities you wanted to show to us or you wanted to go for a presentation? It is up to you.
So
Ma'am,
any investigation?
Madam.
investigations have been done. Yes.
Okay. Okay.
This is 12 lead standardized ECG. Heart rate is around 100 per minute. Normal sinus rhythm, regular. There is
What is the rate? Why you are saying normal sinus rhythm? Is the rate normal?
is around 120, ma'am.
Sinus rhythm. Don't say
Sinus
normal.
tachycardia. Yes, sinus tachycardia. Axis, ma'am, it is right axis deviation is present. There is prominent like S wave in V4, V5, V6. It could be because of RV enlargement, like right ventricular forces are predominant. And
Is this consistent with your diagnosis or not? What you made with the severe MR, severe PAH, severe TR?
right ventricular forces are predominant and right axis deviation. So that goes in favor of like RV enlargement or RV hypertrophy.
What about your LV? What about your LV?
That
LV,
is
ma'am,
major thing. Severe MR you are saying, and
Yeah.
where is the LV forces for you to say that severity?
It's not there.
It's almost
Always
not.
you can say that post-surgery, it alters it.
Hmm.
But still, you expect to be in a child, you don't expect that voltages comes down even after the surgery also.
But
So
clinically,
that
it
is
is
an
saying is, clinically you are saying is to down and out, right?
Yes, ma'am.
Even after post-op,
Yes,
clinical
cardio-
examinations to down and out. But there's no evidence of LV enlargement in ECG. There's no
Is there any LE, left atrial enlargement, is there? ECG?
How is the P wave in V1?
It's negative.
So how much is negative? So you should
It's-
know what is the indices
yeah.
to see
One
that.
box like 0.04 milliseconds and 0.1 millivolt.
So is
in-
that is there or not? Or on the lead 2?
No,
Either of
yeah,
the two. Notching in this in a lead 2 or the changes in the V1. Is
Right.
there or not? Tell directly, star.
In lead V1, it is not. In lead 2 also, it is not there, ma'am.
So is
Okay,
there
go ahead.
any arterial enlargement in this patient, whether RA or LA, any enlargement from the ECG?
No, ma'am. No.
No. Okay. Proceed.
Yeah, even another student said there is no enlargement of the left ventricle. Go ahead. Go ahead. We are already past the time.
Chest X-ray, ma'am. Normal, well-centered, normal exposure. There is a cardiomegaly present.
Go for a positive findings.
LV apex. There is RA enlargement. There is LA enlargement. Then there is this pulmonary base full, and there is evidence of pulmonary venous hypertension.
For you, I will read it. It is a situs solitus, moderate cardiomegaly, predominantly the right atrial enlargement, left atrial appendage enlargement, left ventricular apex, prominent bilateral prominent bronchovascular markings with a prominent PAH, with a prominent PVH and pulmonary arterial hypertension, and SVC is enlarged. So these are the positive findings which you expect to see to that. Go ahead. Next.
Echo.
If it runs, it's okay.
Yeah, tried. It was running.
Okay. Then in the static image, what are you are able to see? Because anyway, you are not able to run that.
There is LA enlargement is there. Then
Can you come out of slideshow and try running it, Aditi? It was running before.
Yeah, it was running.
Just escape it, Aditi. We can get that slideshow
I think
escape mode.
meanwhile, I can advise Rupali better to have a group with these people who are joining so that we are not able to answer all the students' questions. But major intention of ours is to answer to them. So the whoever can't be discussed here, they can put the questions and we can try to answer to them subsequently after the presentation also.
After the presentation.
Yeah.
You can
Sure,
have a
ma'am.
series of
Ma'am,
master classes 1, 2, and 3, and each question you can give the answers in a different form.
Yeah. So if we make a WhatsApp group who joined this time, so that we can they can put the questions subsequently, and we will also
We
try
can
to
answer
answer to them, and we can learn from them. They
You're not able to run,
educative.
Aditi?
Sure, ma'am. Next time we will do
no,
that.
ma'am.
Murugesh.
Murugesh will share, ma'am. He's
Okay.
So you stop sharing, Aditi, if it's possible,
So
you stop sharing your slides so that Murgesh can share.
Do you have anything to show, or we'll go to Murugesh?
Yeah.
no, ma'am. He has the same slides,
And do you have anything?
See
Do
whether
you
it
have
runs
anything
in-
more to show? Anything more to show?
No, ma'am. He has the
Okay.
same slides, ma'am. The eco videos he has, so he will.
You
play.
should start
Please.
sharing, Aditi.
Unshare. Stop share.
How to stop sharing? Can you just tell me?
Niche.
Abhi, ma'am, meantime, she's sharing. There is one very good
So,
question from
yeah.
Dr. Devya Murgeshan, that how to grade severity of pulmonary hypertension clinically.
Now, patients, whether patient having a mild pH, moderate pH, or severe pH, clinically, we have few points to see. For example, if a patient have P2, which is usually lesser in intensity than A2 in the normal patient, you see whether it's a higher and equal intensity, is higher than A2, not palpable, higher than A2 and palpable. So these are the three things. Whether intensity is increased and equal to A2, while it is more than A2, not palpable, is moderate, more than P2 and palpable is severe. Then how long you are able to palpate? For example, P2 had at the pulmonary area, midway up to the apex, up to the apex. Number 3 is parasternal lift. How is the grade of the lift? 1, 2, and 3. And associated epigastric pulsation and subsequent impulse, they say how much is the pitch, mild, moderate, severe. You can grade accordingly clinical. This is clinical.
And second one is the split of the NS2. You want to
Right.
tell about that also, madam?
Right. Second heart sound, whether it's a usual splitting or a narrow splitting, could also be single splitting in pH, because P2 comes earlier towards A2 in pH. Depending upon the splitting also, you can grade the pH. Right. Thank you.
Aditi, it's, I think, taking time. So can you just tell
So
the
what
eco
are the-
findings
read
like
the
that,
eco
because
findings.
we already ate well. So can you just tell the eco findings if the video is
He
From
is
not
this-
not
there?
able to unshare.
From this clip, can you say, Pooja, the RV is enlarged? Can you say? Can you say the RV is enlarged than LV?
From which clip, ma'am? Actually?
From this one. It's not
the
moving,
echo.
the fixed clip.
You unshared, no? Let
I'm
me
unshared.
share it.
Mukesh, can you share it now? Yeah, okay. Can you just run it? Don't make it share slideshow, because last time it was clear. Yeah. Can you just, play it?
Yeah.
Okay, now you can comment.
There is there is LA enlargement, ma'am. RV hypertrophy is there. And there is a valve, both tricuspid and mitral valve mobility is, there is thickening, leaflet thickening, which is seen. The tricuspid valve movement is not well appreciated in this. Mitral movement is, we can appreciate. So this is apical four-chamber view. The color Doppler across the mitral valve. We can see there is severe mitral regurgitation. This is a parasternal long axis view, which shows LA enlargement is there. There is like mitral valve thickening is there, and
Can you see the annuloplasty ring there?
Yeah.
this one, ma'am.
Yeah, this important structure around the annulus could be the mitral valve.
Annulus. Okay. This is the same parasternal long axis view, color Doppler, which is showing mitral regurgitant jet. Severe MR is there. It is filling the left atrium almost. This is vena contracta across, like for the mitral color Doppler. It is 1.06, so it is severe MR, more than 0.7. It is significant.
Is that the vena contracta, or it should come little proximal? Can we go back? Josna ma'am can say better. Is that the vena contracta, or we should go little up?
It's okay, madam, because this is exactly at the annular level, and there is a change of the color at that area. So I think this is okay.
Okay.
And
So
another one is that is reliable after the mitral valve repair.
Vena
One
contracta.
of the methods is an acceptable, but otherwise the previous repair will have an alteration in that, and that too it is not looking like a single jet. Central jet is an predominant, but there is another also wall hugging jet towards to it is an intraatrial septum also. At the time, only to say the vena contracta is not. Either of the case, it is looking like a severe MR. So when you have the doubt about the classification, then probably all these features are going to be even a calculation of the regurgitant volume, but it may not be that much reliable at present in this case.
yeah,
Okay,
even
go ahead.
also we have more than one jets, right?
This is, he has calculated the effective regurgitant orifice area with the help of PISA method, that is around 0.4. So that is also significant for severe ML. Then this he has the M mode across the LV. It is showing a LV-IDD of 5.1, sorry, and LV end systolic dimension of 3.3, and LV function is like normal, around 60%.
No, but actually in this, what we wanted to say the EPSS, because we have the heart failure, we wanted to say in the left ventricular function also, because all other features are says of the rheumatic etiology. Okay, next.
This is the short axis view at the mitral valve level. The mitral valve area is 2.9, so it is normal, and LV function is also adequate. This is the color Doppler across the tricuspid valve, which shows an eccentric jet of tricuspid regurgitation. It is severe. It is filling almost more than 40% of the RA. This is the...
Okay, go ahead. Because...
okay.
Yeah.
This is the...
So, you tell the final diagnosis.
Yeah.
I think, have you done any 4D echo or 3D echo or nothing else is done?
This is pulmonary vein Doppler?
Yes, hepatic vein systolic reversal, ma'am. Hepatic.
Okay. Hepatic,
yeah.
right.
I think we should conclude it now, the presentation. We'll go for the case discussion. We have to go for a presentation. So tell the final diagnosis, and Prabhavati madam will talk about it.
Acquired valvular heart disease of rheumatic etiology with severe mitral regurgitation, with severe PVH, with severe PH, with tricuspid regurgitation, most likely functional tricuspid regurgitation, currently in congestive cardiac failure, that is right-sided heart failure, with in normal sinus rhythm, with no evidence of acute rheumatic fever or infective endocarditis.
Yeah, I'm happy that Ramesh is actively asking questions, but we are not able to talk much because of the lack of the time, as Rupali is going to help us in making a group, and you have your presentation there with the videos so that anyone can have the further discussion on that. So may I request for the Prabhavati madam now? Good presentation, really great.
Right.
And you prepared very well.
Great, Aditi. I think, yes, ma'am, we will just try to answer the question in between the chat box, and we can make it from the next time chat, one group for these fellows who are asking questions. So we are requesting now Prabhavati madam to give small tips and tricks for the regurgitant lesions, how to elicit them, what are the clinical history which you have to be careful about, which I think most of the points Josna madam and Chavi madam have already discussed. Let's have more insight into it. Ma'am, you can share your screen. You can see your screen. You have to go to the slideshow.
Okay. Okay.
Yes, ma'am.
Ma'am, is this your first slide?
No, what happened?
Ma'am, you escape and then click on the first slide on the left side.
Yeah, you can have. Right.
It's okay now?
Slides. Right.
Yeah.
Yeah. Right. Good evening, everybody. After the case discussion, we will clinically approach how to approach clinically regurgitant lesions. Briefly about each valvular lesions with regurgitation. First, we'll start with mitral regurgitation. Mitral regurgitation can be primary due to abnormalities of the mitral valve apparatus. The two most common causes are chronic rheumatic heart disease and myxomatous mitral valve disease. Secondary MR, otherwise called functional MR, is due to LV dilatation and dysfunction due to ischemic heart disease or dilated cardiomyopathy. MR can be acute in infective endocarditis or caudal rupture or papillary muscle rupture in acute MI, or it is chronic, as we already discussed about rheumatic and MEP. It can be ischemic, congenital, or degenerative due to annular calcification in elderly. The symptoms in chronic MR depends on the severity, rapidity, compliance of the left atrium, and the LV function. So chronic severe MR most often has a long asymptomatic period. Palpitation can be the only symptom due to volume overload. Sometimes they develop exertional fatigue due to decreased effective forward stroke volume. Dyspnea is a late manifestation due to LV dysfunction. However, some patients with MR can rapidly progress into heart failure with the dyspnea. In such patients, you have to look for recurrence of rheumatic activity in young children with rheumatic heart disease or caudal rupture, which may be spontaneous in degenerative mitral valve diseases like Barlow's syndrome or due to infective endocarditis. Sometimes in chronic severe MR with a non-compliant LA, they may develop early pulmonary venous hypertension, pulmonary arterial hypertension, and right heart failure. Onset of AF, which is common after the age of 50 years, may rapidly progress into left-sided failure and eventually right heart failure. Chest pain is not common in mitral valve prolapse, but in MEP, there can be atypical chest pain and sometimes it can be typical due to abnormal tension on the papillary muscles. Pulse is not helpful in assessing the mitral regurgitation. It may be irregular in AF, but a carotid upstroke may be sharp, quick rising. That's what they call it a small water hammer or pseudo collapse. There is no change in the pulse volume or blood pressure. It is not really collapsing. It's just a rapid, sharp upstroke because of pumping of blood into the low pressure LA. Precordial motion of MR is in MR is helpful to assess severity. Apical impulse is normal in mild to moderate MR. It becomes hyperdynamic, and the apical impulse is shifted down and laterally in severe MR. It becomes sustained when there is LV dysfunction. There may be a palpable systolic thrill, S3, or diastolic thrill in the severe MR. Another interesting feature of severe MR is the late systolic left parasternal pulsations due to large regurgitated jet into dilated left atrium. This is palpated through the anterior cardiac structures. This is asynchronous with the LV apical impulse. It mirrors a large V wave in the left atrium. There may be evidence of pulmonary hypertension in the form of parasternal heave, PA pulsations, and palpable P2. First heart sound is usually soft because of the early onset of MR during isovolemic systole, which may mask or blur the first sound. S1 can be loud in associated mitral stenosis or mitral valve prolapse with mitral regurgitation because of the freely mobile AML and non-ejection click fusing with the S1. Wide variable split is a feature of severe mitral regurgitation due to delay in the due to early A2, secondary to decreased LV ejection time. This widespread second sound may become narrow when there is LV dysfunction due to delayed A2 or pulmonary hypertension causing early P2 due to decrease in hangout interval. So as Madam pointed out, when they develop RV dysfunction, that can be again widespread second sound due to delayed P2. S3 indicates severe MR due to large flow across the mitral valve. S4 is generally absent in chronic severe MR, especially in rheumatic MR because LV is compliant, it doesn't need the atrial boost, and LA function is decreased because of previous rheumatic carditis and long-standing volume overload of the atrium. However, loud S4 can be featured in acute MR due to HOCM and coronary artery disease. The systolic murmur of MR is pansystolic because it coincides with the S1 and continues beyond A2, obscuring A2. S1 may not be, murmur may not be S1 coinciding in MEP MR, which may be mid to late systolic, ischemic MR due to papillary muscle dysfunction, and MR in HOCM, which starts after the obstruction. Irrespective of etiology, the murmur intensity is best at the apex. It radiates to left axillary and infrascapular area when the abnormality is in the AML, classically seen in rheumatic heart disease. When there is prolapse or fail of the posterior mitral leaflet, the murmur may radiate towards the sternum and the base and may be mistaken for aortic stenosis. This may also happen in AV septal defect and CCTGA with left AV valve regurgitation. Murmur may be soft or absent when it is due to dilated cardiomyopathy and MR related to coronary artery disease and sometimes in paraprosthetic valvular regurgitations. A low-pitched mid-diastolic decrescendo murmur may be associated with thrill is a feature of severe mitral regurgitation. It is differentiated from MS because there is no pre-systolic accentuation. Sometimes this MDM may be absent in spite of severe MR when there is LV dysfunction or associated ASD or acute MR. So to summarize the clinical features of chronic severe MR, cardiomegaly with dilated hyperdynamic LV, late systolic left parasternal pulsations, that is LA pulsations felt through the anterior structures, wide variable split of the second sound due to delayed aortic component, LV-S3, which may be palpable, with a mid-diastolic murmur. Intensity of murmur may not help, but if there is a loud murmur with a thrill and widely radiating, it indicates severe MR. And pulmonary hypertension is a late feature and it indicates severe MR. We need to differentiate MEP MR from rheumatic MR. Non-ejection click and a late systolic murmur helps in differentiating, and the dynamic auscultation should be used whenever there is doubt about the etiology. Acute MR presents with soft S1, loud P2, S3 and S4 are invariably heard, but the murmur becomes early systolic decrescendo because there is rapid equalization of pressure in the left atrium. Moving on to aortic regurgitation. Aortic regurgitation can be due to primary disease of the aortic valve like rheumatic heart disease, bicuspid aortic valve, or aortic root disease like in Marfan's or bicuspid aortic valve syphilis. Nowadays, less often seen. Again, chronic AR has a long latent period. Initially, palpitation at rest or exhaustion may be a dominant symptom. They may have some pulsations in the neck. Marked systemic vasodilatation may lead to increased sweating and warm flushed skin. Angina, which may be exertional or nocturnal, and dyspnea are late manifestations. Nocturnal angina may be troublesome. It may be due to decrease in the heart rate, which prolongs diastole, decreases coronary perfusion pressure and coronary blood flow. It can also be due to Venturi effect of AR jet, causing flow reversal in the coronary arteries. Dyspnea is a late manifestation, but if occurs early in the course, suspect acute AR either due to infective endocarditis or think of associated mitral stenosis. Severity of AR is assessed by peripheral signs, wide pulse pressure with low diastolic pressure, Hill sign, cardiomegaly due to dilated hyperdynamic LV, long early diastolic murmur, and an Austin Flint murmur. So we all know that a Hill sign is an important sign to assess the severity. Though it is a sphygmomanometric artifact, it is useful. It may be fastly low when there is LV dysfunction, acute AR, or other valvular lesions. For all peripheral signs may be masked by LV dysfunction or associated other valvular lesions. Disvariance pulse, 2 peaks in systole, where both may be equal or the second peak is more than the first peak. This is classically seen in severe aortic regurgitation. This is supposed to be due to Venturi effect. Rapid jet has a suction effect which causes mid-systolic dip. Blood pressure should be measured in both upper limbs and one lower limb at least. Severe AR, systolic BP is usually higher, 140 to 150. If it is less than this, you start suspecting of associated other lesions or LV dysfunction. Diastolic BP is less than 50. It indicates significant AR. Sometimes you may hear the Korotko sounds up to 0, but intravascular diastolic pressure doesn't go below 30. Wide pulse pressure is a feature of severe aortic regurgitation. The basis of peripheral signs is wide pulse pressure and a low diastolic pressure. Systolic BP is higher because of increased stroke volume, and diastolic BP is low because of reflex vasodilatation and fall in systemic vascular resistance. The most important peripheral signs are Hill sign and Durosi sign. Durosi sign indicates central runoff, that is diastolic runoff, which can be heard in other conditions also like PDA and rupture sinus of Valsalva. Precordial examination. Moderate aortic regurgitation, apical impulse may be hyperdynamic but not shifted. As the severity increases, it becomes more hyperdynamic, shifted laterally and inferiorly. It may become diffuse, at least occupying 2 intercostal spaces. Once there is LV dysfunction, apical impulse becomes more sustained. S1 may be soft in LV dysfunction. A2 is delayed due to longer LV ejection and increase in aortic hangout interval. However, paradoxic split is uncommon unless there is LBVB or LV dysfunction. A2 may be soft in valvar AR, but normal or loud in aortic root abnormalities. Here, S3 indicates LV dysfunction, especially in older adults. It may be physiological in younger age. Early diastolic murmur heard along the left sternal border, best in the left third space, indicates aortic regurgitation. The murmur becomes longer as the severity increases. If it occupies more than half of diastole, it indicates severe aortic regurgitation. If the murmur is best heard in the upper right sternal border, it is due to aortic pathology, root pathology. Austin-Flint murmur is a mid-diastolic and pre-systolic murmur due to AR jet impinging on the AML causing relative mitral stenosis, that is seen in severe aortic regurgitation. This needs to be differentiated from mitral stenosis murmur. There is no pre-systolic accentuation, and if there is loud S1 opening snap, it favors associated mitral stenosis. Ejection systolic murmur due to large stroke volume is heard in moderate to severe aortic regurgitation. It's usually short and early peaking, unlike organic aortic stenosis, which is harsh, raspy, long and late peaking. AR due to root pathology, there may be dullness in the right upper sternal border. A2 may be loud, like tambour quality in syphilitic AR described earlier days, and the murmur is heard best on the right sternal border, whereas valve pathology may be A2 soft and diastolic murmur is heard in the left, best heard in the left third intercostal space. Acute AR, there is no peripheral sign. Patient may present with acute heart failure or pulmonary edema, tachycardia, elevated JVP, palpable S3, loud P2, short soft EDM are features of acute aortic regurgitation. Moving on to tricuspid regurgitation, most often it is functional, caused by dilatation of the annulus secondary to right ventricular systolic pressure elevation, secondary to left-sided diseases. Small percentage organic due to direct involvement of the tricuspid valve. In rheumatic heart disease, it's always associated with mitral valve disease. The common symptoms are due to low cardiac output, weakness and fatigue. Right heart failure symptoms predominate, as in our patient, which was discussed. There are some non-cardiac findings in severe TR. Pulsatile proptosis, icterus, engorged neck veins, earlobe pulsations, head bobbing. There is no movement, that is lateral, sidewise. Hepatomegaly with systolic pulsations, ascites, splenomegaly. All these were seen in our patient, except splenomegaly, peripheral edema, cachexia due to protein losing enteropathy in late stages. JAP is a useful clue to assess the severity of TR. As the severity of TR increases, there is attenuation and obliteration of the X descent. The CV wave becomes prominent, called Lance's sign. Y descent is prominent unless there is significant tricuspid stenosis, and pistol short sounds may be heard over the jugular veins. This is an example of a patient with severe tricuspid regurgitation with engorged neck veins, prominent CV wave, and head nodding side to side. Severe TR, pansystolic murmur in lower left sternal border, which increases on inspiration, and passive leg raising. It should be passive. We should not ask the patient to lift the legs. This inspiratory augmentation may be lost or decreased when there is RV dysfunction. RVS3 and short MDM in lower left sternal border may be there in severe tricuspid regurgitation. So commonly asked question, how to differentiate high pressure versus low pressure TR? High pressure TR will have features of pulmonary hypertension like parasternal VU, loud P2, and prominent CV wave on JVP, pulsatile liver. The murmur is high-pitched and pansystolic, whereas low pressure TR, due to organic involvement of the tricuspid valve, JVP and hepatic findings are less prominent. The murmur is early systolic, decrescendo, low to medium pitched murmur because there is early equalization of pressure. Sometimes it may be soft or inaudible, like in RVMI or EMF. Briefly about pulmonary regurgitation. Again, most often it is high pressure PR, secondary to pulmonary hypertension. Uncommon causes like congenital absence of pulmonary valve, post-op repair with transannular patch and infected apparatus of pulmonary valve cause low pressure PR. So whenever there is PR, we look for clinical features of pulmonary hypertension like prominent A wave, parasternal heave, epigastric pulsations, PA pulsations, dullness in the left second space, loud palpable P2 which is widely heard, including apex. Pulmonary ejection click is a feature of pulmonary hypertension, and TR and PR murmur may be heard. So another important question always asked is how to differentiate high pressure versus low pressure PR. High pressure PR, there will be findings of pulmonary hypertension. The murmur is high pitched, starts immediately after P2, it's longer and maybe even pan diastolic. Whereas low pressure PR starts after a gap, pitch is low to medium, it's short, maybe crescendo, decrescendo, because equalization of pressure occurs early. So to conclude, thorough history and proper physical examination can establish diagnosis in majority of the patients. Despite numerous technologies, clinical skills remain crucial in the assessment of regurgitant lesions. Thank you.
Thank you, ma'am. Thank you for a very nice and a succinct presentation in such a short time. And you mentioned all the very important differential points for clinical examination. Ma'am, I think there is one doubt cropping up in the chat box. I think students are asking whether S3 always suggests severe MR. So they want clarification on that point.
Actually, the MR's, the severity, the S3 is a borderline. Definitely, the presence of the S3 can happen in the moderate MR also. And
Yes,
if the associated with this, even MDM can be the S3 or MDM can happen in the even in the moderate MR. If you really the moderate MR, if you classify as a low moderate or the moderately severe, then it is likely to be present in moderately severe. So these two are the not sufficient enough to definitely to say that the patient has the severity of the severe MR. So that's why other associated than cardiomegaly and the split of the S2 will be taken as a criteria to definitely to classify it. But S3 definitely will be present in the severe MR.
Yes. So anyone has any other questions? I think we'll try to make the video recording available so that whatever points you can recollect, you can go through it again and you will be able to see the videos and the case presentation also.
And there is one question for how do you distinguish the palpitation of the MR versus AR? There is not much of the difference. Some people will say that the palpitation is more frequently nocturnal in the case of an AR and can happen even at the rest in the case of an AR, whereas an MR is usually exertional and it is present in the either of the time more frequently in the morning. But that doesn't really distinguish the MR from the AR palpitations.
Now to Prabha madam, just for the students' sake, now how to differentiate the parasternal lift, whether it belongs to pressure overload of the RV or from volume overloaded RV. And why the P2, the murmur starts little after P2, non-hypertensive and hypertensive just with P2. Why the difference?
The parasternal heave, it should lift more than 50% of the systole. If it is pulsation, it is less than half. It is something like our hyperdynamic LV and giving apical impulse.
And usually associated intercostal pulsations, if they're diffusely seen, we always say it's a overloaded RV, volume overloaded. So if it stays and goes back, it is pressure. If it's not staying for more than half and the intercostal pulsations are well seen, we teach the students it's a volume overload. Rupali, anything you want to add to that?
Yes, ma'am. I think that I agree. Most of the points have been discussed and we have already crossed the time at 8:40.
Right.
So there were like a very, if chairpersons and panelists allow me, so can we conclude this session? So
thank you, Rupali.
Thank you
so this
so
is
much,
the first e-class which we tried to organize during this 2024. And I'm really, I was a little skeptical in starting this, but by seeing the response of the residents and by the faculty in such a short notice with very good case presentation by the resident with well prepared, I think this classes will be more fruitful for the residents. And these recordings they can clearly see from our Wincars website. We will upload these recordings with these presentations, and it will be useful for all the fellows. So I thank Jyotsna madam for giving us the platform to start these e-classes. And I really thank Prabhavati madam for such a short notice, helping us out in this, presenting a very important presentation in which exam-oriented questions, which are usually asked, for how to differentiate between low pressure PR and high pressure PR. So this will be very useful for the fellows who are going for exam. And Shabi madam and Jyotsna madam, the questions asked, I think they will prepare on the skills of the residents to how to prepare for the exams. And I'm really grateful to Dr. Usha and Dr. Hema for coordinating these e-classes. So any final words from you, Chabi ma'am, Prabha ma'am, and Jyotsna madam?
Pali, it's actually a great thing because with just such a short notice, I could find like more than 60 residents have logged into this e-class, first e-class that you have arranged.
At one point, there were 80, ma'am.
Oh, it has gone to 80. Okay, I couldn't notice, right? That's good. Good.
Thank you, ma'am. I think the case discussion made it more interesting.
Yeah.
And the points are much easier to remember when we hear that in the case rather than just a presentation. Thanks to Jyotsna ma'am for this idea of putting case presentation. Thanks a lot for the discussion, ma'am.
Thanks to everybody.
Thank you. Thank you, Prabha ma'am. So nice of you presenting. We also learned many things from you, many new terms.
Yes.
Every time we are learning, right? Thank you.
Thank you.
I made some notes also. I don't know when
Yeah,
I was
I have written
presenting.
two, three things I have written from Prabha madam's lecture also.
Yeah. Thank you, ma'am. Thank you, Jyotsna ma'am, for giving us the
Jyotsna ma'am,
opportunity.
are you there?
And thank you,
Ma'am.
Prabhavati ma'am. She's been my teacher all along and never ceases to amaze me with her teaching skills. And thank you, Kabi ma'am, very much. Thank you, Dr. Usha. And thank you, Dr. Rupali, for giving me the opportunity. Thank you so much.
Thank you very much.
Yeah, I think whoever wants to be in the WhatsApp group, we can create one only for academics.
Yeah.
So that the common invite can be sent to them for every meeting.
Just one thing I want to say, Rupali, if you're trying to start a WhatsApp group for the e-classes, just give a limit, like within 2 weeks or 3 weeks, whatever question will come. Then you close this and again start for the new classes. That will be better, I think. Otherwise, questions will be coming throughout the year. So e-classes,
within 2 weeks of the presentation, whatever the questions come, we can respond them.
Right. Thank you.
Thank you, ma'am.
Bye-bye.
Bye, ma'am.